patient to be in a state of light sedation where they're able to cooperate, hold still, and maintain their airway and breathing. Or general anesthesia, and we have an airway device that we're able to place and breathe and help assist with their ventilation. The gray zone is where the patient is in a moderate or deep state of sedation, where under the microscope, any movement translates into a large movement. And a patient who is moderately or deeply sedated can require interventions that can cause compromise to the progression of surgery. So anesthesia and analgesia for ophthalmic surgery fall into two big categories. Or one is topical analgesia or anesthesia, where the patient gets drops to the surface of the eye, and others that involve a block, which Doctors Palti and Jeffrey will speak more about. In terms of perception of pain and discomfort during the surgery and during analgesia administration, patients who receive topical anesthesia report no pain, and patients who receive any kind of needle-based or cannula-based might report some pain upon administration of the analgesia. During the surgery, patients who receive a block are likely to report less pain than those who receive topical analgesia. So can ophthalmic surgery proceed without sedation? The answer is yes. With good patient education, surgeon encouragement and input, realistic expectations from the team, verbal reassurance, and a team discussion and decision that's made, weighing the risk and benefits for a patient who's motivated and or very frail, the best option might be to do it with good topical or regional block and without much sedation on board. And the backup plan is always for sedation or general anesthesia. Benefits of sedation for ophthalmic surgery during the COVID pandemic is that with sedation, you're less likely to need to manipulate the airway and potentially aerosolize contents in the oral pharynx. You still have to be aware of the sneeze reflex that can occur during propofol boluses and in patients who are getting the block or analgesia done under bright lights. And being more versatile in terms of your techniques and medications that you use, you're less likely to be affected by drug and equipment shortages that might have gone to the care of patients in the ICUs or requiring further management in a more acute setting. Propofol is a very effective sedative for both topical and ophthalmic blocks. Propofol, a bolus, can be given for block administration as well as continuous infusions for sedation. If the patient needs to be converted to general anesthesia, a larger dose of the medication can be used for induction of general anesthesia. And with small boluses or small infusions, it's a very good antiemetic, which is one of the considerations in patients who are receiving ophthalmic surgery. For sedation, the infusion usually is at 25 to 75 mics per kg per minute IV. Patients who are getting higher than that run a risk of being in a moderate or deep plane of sedation and can cause disinhibition, requiring intervention of the airway or other interventions. So the sedation that's optimal would be at a lower dose. This is a recipe that was outlined by Dr. Dumas, and which I follow at my institution quite a lot, using different medications and knowing the flow of your surgeons and when to give these medications. Now, recognizing that they peak at different times and using them to treat the type of clinical goals that you'd like to accomplish. So midazolam for sedation, fentanyl for pain and squeezing of the lids during the block, ketamine for a dissociative state and for analgesia, as well as propofol for deep sedation for patient comfort during the block. So harnessing the benefits of each drug is very important, knowing when the maximum and peak effects of the medications take place, and if there's reversal agents, if there's any that can reverse the medications, should the patient's reaction to the medication be more intense than what's expected. So midazolam and fentanyl are two of the common medications that are used to provide sedation for the patient. Ketamine, I'm happy to see a lot of discussion in the SAMBA website about ketamine being used for sedation and analgesia. In small boluses, it's a great medication, and it can be used in combinations with midazolam and propofol to administer to provide a state of sedation and provide analgesia for the patient. Things to consider are patients can get an increase in salivation with these at higher doses. However, it has many good benefits, including being beneficial for patients who are chronic pain patients and who might have less sensitivity to some of the opioids that are used. So for sedation and analgesia, the recommendation is to use 0.2 to 0.8 mg per kg IV over a slow bolus infusion. Dr. Fang outlined a technique called the 622 mixture, a mixture of propofol, alfentanil, and lidocaine. And when he administers this to patients with some changes according to their frailty or their age, he noted that after 1 minute, the patient was reliably in a state of sedation in which the block was able to be administered with stable cardiovascular status, as well as a consistent patient satisfaction. In addition